All right, today we're tackling a real classic, a diagnosis that is an absolute must-know for your pathology exams, celiac disease. And we're going to treat this like a real investigation, a case file, following the clues from the patient's very first complaint all the way to that final definitive pathology report.
So get this, your patient's got all the symptoms, the blood work is pointing right at celiac disease. But, suspicion isn't a diagnosis. You need proof. So what's going to give you that final definitive answer? It's the duodenal biopsy. That little piece of tissue is our smoking gun, and today we're going to learn how to read every single clue it holds. But hang on, before we pull out the microscope and zoom all the way in, we've got to zoom out. What brought the patient to us in the first place? We need to understand the whole story, from that initial clinical puzzle right up to the moment the biopsy slide lands on our desk.
So what is celiac disease, officially? Well, here's the definition. And the key phrase, the one I really want you to lock onto, is chronic immune response. See, this isn't just some simple allergy. This is the body's own immune system launching a full-scale, relentless attack on the small intestine every single time gluten shows up. Getting that distinction is absolutely fundamental.
The hunt usually starts with blood work. A really powerful screening tool is the TTG antibody test. That's for tissue transglutaminase. Now, it's about 90% sensitive and specific, so it's a very, very strong first clue. But it's not proof. It just builds the case. To truly confirm the diagnosis, you have to see the damage with your own eyes, in the tissue itself.
So how does this all go down? To really interpret a biopsy correctly, you got to understand the crime scene. What's the sequence of events that turns something as simple as a piece of bread into an all-out assault on the intestinal lining? That whole process, that's the pathogenesis.
And you know what? It all starts with genetics. And man, just look at how strong this connection is. Something like 95% of patients with celiac disease have the HLA-DQ2 gene. And most of the other 5%, they have HLA-DQ8. The bottom line is this: if you don't have one of these genetic markers, a diagnosis of celiac disease is extremely unlikely.
Okay, so here's the chain reaction. Step 1. A person with that genetic predisposition eats something with gluten. Step 2. Their immune system freaks out. It mistakenly flags gluten as a dangerous invader and launches a huge inflammatory response right there in the wall of the intestine. This inflammation becomes chronic, and eventually it just destroys the villi, those tiny, crucial, finger-like structures that absorb all our nutrients. Once the villi are gone, so is the ability to properly absorb food.
And this brings us to the moment of truth. The biopsy's been taken, it's been processed, it's on the slide, and we are now looking down the barrel of the microscope. This is the big reveal. This is where we find that definitive, rock-solid evidence of the whole disease process we just mapped out. And wow, the evidence is just undeniable. On the left, you see a healthy duodenum. You've got these long, elegant, finger-like villi just maximizing that surface area for absorption. But on the right, you see the devastation of celiac disease. The villi are blunted, flattened, or totally gone. That is villus atrophy. The crypts underneath are all stretched out and elongated, trying to compensate. That's crypt hyperplasia. And maybe the most important clue of all, the lining is swarming with immune cells, specifically lymphocytes.
Now let's zero in on those lymphocytes for a second. Pathologists, we literally sit there and count them. In a healthy gut, you might find, say, fewer than 25 lymphocytes for every 100 of those intestinal lining cells, the enterocytes. But in celiac disease, that number just explodes. A count of 30 or more, that's a critical piece of evidence. It's a clear, quantifiable sign of that ongoing immune attack.
So we found our evidence. The key features are there. But our job isn't quite done. Now we have to actually assess the extent of the damage, grade the severity, and, this is crucial, rule out any imposters. Other conditions that can look a lot like celiac disease.
Now, to make sure everyone is speaking the same language, we use the Marshall-Overhuber classification system. It's basically just a grading system that tells us exactly how severe the damage is. It starts at a type 1, where you just see an increase in those lymphocytes, and it goes all the way up to type 3, which is that classic severe villus atrophy we've been looking at.
Okay, before we sign out this case, we have to talk about the lookalikes. And the big one for celiac disease is giardiasis. An infection with the parasite Giardia can actually cause a villus atrophy that looks shockingly similar under the microscope. So a pathologist always has to carefully scan the slide, looking right in between the villi for those little pear-shaped parasites to make sure we're not missing it. It is a classic pitfall.
All right, let's pull all of this together.
We've followed the clues, we've analyzed the evidence, we've cracked the case. Now let's package this whole thing into the perfect answer for your oral exams. This is exactly what you need to know to absolutely nail this topic when your professor asks.
These are pretty much guaranteed to be the kinds of questions you'll get. The histologic triad, that genetic link, the grading system, the main mimic. Go on, hit pause right here and try to answer each one of these out loud. Think of it as your practice run.
And here it is, your perfect 2-minute summary. When your professor asks you to summarize celiac disease, this is what you deliver. Celiac disease is an immune-mediated enteropathy triggered by gluten in genetically predisposed individuals, primarily those with HLA-DQ2 or DQ8. Diagnosis relies on a duodenal biopsy showing 3 key features: villus atrophy, crypthyperplasia, and increased intraepithelial lymphocytes typically exceeding 30 per 100 enterocytes. We use the Marsh-Ober-Huber classification to grade severity, and a key differential is giardiasis. That's it. It's clear, it's structured, and it's complete.
So we'll leave you with one last question to really push your thinking. You've made the diagnosis, your patient starts a strict gluten-free diet. Now, if you were to get a follow-up biopsy a year from now, what would you expect to see? How would the histology, the tissue itself, prove that the treatment is working? That's the next step in the investigation. Thanks for joining us.